Hello and welcome everyone to today's Precisionary Instruments webinar on microindentation of fresh, soft biological tissue. And it's my pleasure to introduce Dr. Clíona McCarthy, who is now a Senior Research and Development Engineer at Stryker. She has a background in nursing, biomedical engineering, and a PhD in vascular tissue characterization. So Dr. McCarthy specializes in standardizing fresh tissue sectioning protocols to improve precision and reproducibility in biomedical research. Today, she's going to share her insights on micromechanical tissue characterization, tissue preparation, challenges, and their impact on soft tissue research. We'll have a brief Q&A at the end, so feel free to ask questions in our chat as well. And with that, I want to hand the microphone over to Dr. Clíona McCarthy and say thank you so much, and we're really looking forward to your talk today.
Thank you very much for the introduction, Abby. So I'll jump straight in and do a quick introduction. So I suppose, first of all, the focus of my PhD thesis would have been looking at micromechanical tissue characterizations. And I suppose anyone who is in the field of mechanical characterization would know that a lot of the data out there in literature looks at macro scale mechanics. And while that's very useful for doing bulk characterizations of biological tissue and gives us very important data, when we go down to, I suppose, disease progression and new changes that might happen in the extracellular matrix, this is where the world of micromechanics and the importance of that type of tissue characterization comes into play. You'll see in the images on screen, on the top right image, you would have microscale mechanical profile. You can see the tip of the indenter in the bottom right hand of that picture indenting on porcine colonic tissue, and you can see very distinctly the different layers of the tissue. And in the bottom picture, you see our macro scale representation of macro mechanical compression testing. So you can see very clearly here the differences with micromechanical testing. You can get down to regional differences, and even you can see very clearly the differences that occur within the layers of the tissue. And that would be, I suppose, why I would focus on micromechanical as opposed to macromechanical tissue characterization, to look at these regional differences that occur within the tissue structure. However, before I could begin any of this micromechanical characterization, I noticed that the preparation procedures for sectioning and preparing tissue for microindentation, there was a lack of standardization across all protocols. And while some protocols are very in depth about one particular type of tissue, there was a lack of standardization for a protocol that could be used for various types of tissue, and then if you could apply it to various types of tissue, often the tissue wasn't fresh, and we know from literature that freezing or fixing and freezing of the tissue can cause mechanical changes to the tissue. So the focus of my research was not only to look at micromechanics of tissue, but micromechanics of fresh tissue, so we could try and represent physiological conditions as closely as possible. So the start of my thesis work would have looked at standardizing a sectioning and mounting protocol for fresh tissue to look at it for downstream microindentation. So then the focus of this talk, just for more of a case study focus, would be applying these methods to vascular tissue, which again would have been one of the main areas of focus for my PhD thesis. So I would have worked mainly on peripheral arterial disease. So we know that as with any type of arterial disease, is generally caused by atherosclerosis, which is built up of plaque in the arteries, causing a narrowing of the arteries and restriction of blood flow to the areas here. In the peripheries, so there's a global prevalence of 240 million people worldwide who were affected by peripheral arterial disease. It can be caused by smoking, high blood pressure, high cholesterol, or obesity. It has a lot of complications, some very, very serious ones, including myocardial infarction, stroke, and critical limb ischemia, where your limbs are at risk of being amputated if blood flow cannot be restored to these areas. So medication would be the first protocol for, treating the underlying causes such as high blood pressure and high cholesterol. Then you'd have more surgical options such as angioplasty or stent placement. And then one of the last, treatment methods would be revascularization with a bypass surgeries in an effort to promote blood flow back to the affected limbs and prevent an amputation. So revascularization is the only proven treatment option for limb salvage in critical limb ischemia. There's a seminal paper, the Basel trial, which shows that bypass surgery has the best late-stage patency out of all treatments available. And then out of these bypass options, the great saphenous vein is the gold standard autograft used in these surgeries. Unfortunately, the great saphenous vein is not suitable in up to 40% of patients. This may be due to the length of the vessel available, the lumen size, or presence of varicosities within the vessel. So clearly, there is a clinical need for alternative autograft conduit options for this type of surgery. We know that commercial conduits are available, but autografts still have better long-term patency when compared to your commercial conduits, such as xenografts or synthetic conduits. For peripheral veins, there is a paucity of studies on peripheral vein suitability. For example, the popliteal vein, the superficial femoral vein, and the tibial vein. And then we know that varicosities are tortuous dilated superficial veins in the lower extremities, and they can be caused due to valve malfunction, wall dilation, and increased venous pressure. There's complex etiology around this, but to date there's no scientific evidence to show that these vessels cannot be used for as an autograft option. So in some smaller case studies, there has been reports of success using a varicose vein as an autograft option when reinforced with PTFE, and it may be contraindicated to use synthetic grafts in certain cases, such as this study here, where the patient in question, the synthetic conduits were not an option because she had a comorbidity of sepsis, so they used a varicose vein, and it had good late-stage patency in up to 2 years. So I suppose, I've shown the importance of the need for alternative conduit options, and I suppose some of my work would then to be how do you scientifically evidence this? So again, drawing your attention to what I would have spoken to earlier, part of my talk is why microscale mechanics, why fresh tissues. This would be in some of my previous work to demonstrate why fresh microscale mechanical properties would be the best way to gather this data and compare the alternative options to the great saphenous vein as an autograft option in this surgery. So I suppose then the question that arose was, can microscale fresh tissue characterization identify these alternative autograft conduits? So then for the design of experiments, I wanted to compare mechanically, geometrically, and structurally synthetic conduits, xenografts, peripheral veins, and varicose veins to the gold standard great saphenous vein. So the method developments that I looked at here, I developed a lab protocol for fresh soft biological tissue, including rapid tissue sectioning using the compressed dome and mounting of tissue for downstream microindentation. So the tissue would be isolated on the day of surgery, embedded in a mixture of agarose and gelatin solution, cooled rapidly, mounted into the compressed dome, and then sectioned between 200 to 400 microns, where it was then mounted onto liquid agarose and gelatin, and then hydrated and tested within 2 hours for microindentation. And then I have a video of the sectioning using the compressed foam. So this would be an example of one of the tissue types used for this study. So I believe this is a porcine colon section being sectioned to around 400 microns for use for downstream microindentation, where it would be mounted onto a slide and then further secured into place for downstream microindentation. This is an example of the various tissue types that I've applied this protocol to, including human and animal tissue, ranging from colonic tissue to arterial tissue to plaques to liver and testicular tissue most recently. So then for microindentation, I used the Chiaro nanoindenter, which operates by lowering a probe tip into contact with a sample, which then generates a force displacement scan of the tissue area. So I carried out a 5x5 matrix scan spaced 100 microns apart to get a mechanical profile of the tissue in question. And this is an example of an area that I would have indented on in a vascular tissue ring. And you can see the profile there for the mechanical data that would give you. So then for the vascular study, we wanted to look at the collagen and elastin content of the tissues to give us a better idea of the mechanical integrity of the tissue. And then for the synthetic grafts that I would look at, or the commercially available conduits for the xenograft and synthetic graft, I carried out an SEM analysis to do more of a structural analysis on these type of conduits. So then I'll briefly go through some of the results from this vascular study. You can see the patient profile here. The majority of the samples would come from our varicose vein cohort, which would make sense because a lot of these patients would be electing to have this surgery, while the rest of the veins, such as the great saphenous vein, the tibial vein, the superficial femoral vein, and the popliteal vein, may be harvested due to trauma or amputation on the leg itself. So you can see some of the age profile that was carried out in this study. The mean age would be just over 60 years of age. You can see across the peripheral arterial disease prevalence across the studies, our mean age was just over 40 years of age. Again, the varicose vein cohort would have been quite younger than the remaining cohorts. And you can see that there was predominantly male participants in this study. You see there's a wider or a more even split between the varicose vein cohort and the rest of the cohorts, but that would be kind of your typical prevalence of peripheral arterial disease in general, that patients who have peripheral arterial disease tend to be the majority of those patients would be male. So then I suppose going into the mechanical, geometrical and structural data for the different groups I would have looked at when comparing back to the great saphenous vein. You see, first of all, that for the synthetic conduits, there's a significant mechanical difference when compared to the great saphenous vein. We see the wall thickness here, the synthetic conduits again were thicker than the great saphenous vein. And then when we look at the structural data, you see that you can there's very defined layers within the great saphenous vein, whereas especially for the synthetic conduit 1 and 2, it was very unstructured and not at all like the great saphenous vein, and it's attempted to mimic the layers of the blood vessel in question. So then when we compare the great saphenous vein to the xenograft, again there is a mechanical difference between the great saphenous vein and the xenograft. You see that xenograft isn't as stiff as the great saphenous vein, or is stiffer than the great saphenous vein, but not as stiff as the other synthetic conduits that would be available. So then for wall thickness, they're pretty well matched. There was no significance between the data here. And then for the collagen and elastin content, you see that the collagen content is lower of the xenograft is lower than the great saphenous vein, and that there was a negligible elastin content in the xenograft when compared to the great saphenous vein. So then when we look at the mechanics of the great saphenous vein when compared to the popliteal vein and the superficial femoral vein, we see that there is a significant difference between the tibial vein and the great saphenous vein, and there's no significance between the popliteal vein and superficial femoral vein. Then when we look at the wall thickness, we see that there is a difference between the wall thickness and the lumen when compared to the GSV and the other peripheral veins available. And then structurally, while initially the structure doesn't look particularly different, when we scale it up, you can see that the popliteal vein, for example, is significantly larger than the superficial ephemeral vein, or the popliteal vein. So then going into collagen content, the collagen content of the popliteal vein and the superficial femoral vein tends to be higher, whereas the tibial vein tends to be lower across collagen and elastin contents when compared to the great saphenous vein. So then comparing the great saphenous vein to varicose veins, mechanically we see that there's no significant difference between the great saphenous vein and the varicose vein. This also carried forward through the wall thickness. We see that there's minimal significance between the great saphenous vein and the varicose veins in terms of wall thickness, while there's a larger median spread with the interquartile range for the varicose veins. We see that the median is closely matched between the great saphenous vein and varicose vein. And again, we see that the collagen and elastin content of the great saphenous vein and the varicose vein are similar in content. So I suppose to summarize all that data, out of the different cohorts examined, the closest mechanical conduit explored to the great saphenous vein was the varicose vein cohort. This also followed through with geometrical data. We saw that geometrically the varicose vein cohort are more closely representative of the great saphenous vein cohort examined. And then for the structural content, we saw that the collagen and elastic content of the varicose vein cohort more closely represented the great saphenous vein baseline when compared across all the different groups examined in the study. So before I finish up, I would like to thank our research nurse for all her help with the ethics and transporting and collecting samples on the day of surgery. And thank you to my supervisors and collaborators, John Mulville, Prof. Walsh, Prof. Kavanagh, Mr. Madani, and Tony Maloney. And thank you to our patient cohort, without whom this study would not be possible. So again, I'd like to thank Abby for having me here to present my work, and I'll open the floor to questions now.
Thank you so much, Dr. McCarthy. It's a pleasure because we've known you over the years in your work using our compressome to study tissue. And it's great to hear about your work now. And we hope you're having a really good time at Stryker as in the next step of your career. So at this point, I wanted to open up and see if there are any Q&As. If you have any questions, please feel free to ask Dr. McCarthy or put your question or comment into the chat, and I'm going to monitor it to see if there is anything. We haven't gotten anything yet, but please don't be shy. I'm just going to give it a moment. And if we don't, then please feel free to also reach out to me and I can connect you with Dr. McCarthy if needed. And with that, we want to thank you so much, Clíona McCarthy, for your talk. And I'll be in touch as well.
Thank you very much.
Thank you very much. Bye-bye, everybody.
Bye.